Now, we have been talking about RNA viruses, respiratory viruses. Now we're talking about a DNA virus, the adenovirus. Adeno, as you know, comes from lymph node, which is where it was first described from. And this is a DNA virus, but it's also a very, very important respiratory pathogen. And more than just a respiratory pathogen, I want to say that this is really a chameleon because it can have many, many colors, many, many different kinds of infections. And there is probably every organ system has had some description of an adeno-associated illness. So let's start by talking about the history about the adenovirus. It was discovered from the adenoidal tissues. As you know, the 50s were great times for virologists. Cell culture was established. They were able to grow these viruses, and here they were also able to associate the diseases caused by viruses by looking at the clinical specimen and growing them. So this is one of the viruses that was recognized at that time. And the family Adenoviridae and the genus Mastadenovirus is where these viruses belong. But to remember that these can be avian and mammalian pathogens too, but the human adenoviruses is what we're going to actually be talking about. This is what the virus kind of looks like, and it has the icosahedral symmetry. We will talk about a little about that in a bit. Okay. Oh, that did not scan very well. Okay, I'm going to skip over that and do this. The classification is not at all important for you, so please do not pay attention to this and try and memorize it. I don't know it myself. What I do want you to know is the clinical syndromes. I want you to know, if there's anything you can remember about this slide, is this little group here, F4041. Remember it. Enteric pathogens, group F. If you can remember that, you've got what you need out of this slide. But just to say that the classification is classified into these subgroups, and each subgroup has several serotypes. And many serotypes are actually being still discovered and being added on. So the human adenoviruses are, now described as 49 or so different serotypes, but this is not the end of the story. So the structure we talked about is the non-envelope DNA virus, and the size is about 70 to 90 nanometers. And the genome is double-stranded DNA. We'll talk about the structure over here. I'm going to go to the slide first here to give you this picture and now go back and tell you that it is an icosahedral capsid with 252 capsomeres, which are these individual little units here. And remember, at the vertices, you have these structures which look like a projection with a little knob. And these are called the fibers. And on the fibers, you have a terminal knob. And this, what houses the fiber and knob, is a penton, which is at the vertex here. So this is an interesting graphic structure, and this is a schematic for that, where you have the core, which has the double-stranded DNA. Going outwards, you have the capsid here, which has this complicated structure, and then you have these little antennae over here. And as you can imagine, these are the parts that hit the cells first. And so over here, you have the mechanism for viral attachment. This is an electron micrograph where those little things have separated like tadpoles, but they were actually supposed to be attached over here. Schematic again, the individual units on the capsid are called the capsomeres, the 252 of them, and then the vertex units are called the pentons. Hexons and pentons. Any questions so far? Okay. Now we go on to the actual pathogenesis. We know that this can be a respiratory pathogen, but it can also affect mucoepithelial cells of other tracts. And once it spreads to these tracts, it replicates there, it spreads to the lymphoid tissue, which is how it got to the adenoids when it was first discovered. And then, if it replicates in the lymphoid tissues, it can spill over into the bloodstream, causing viremia. Once it gets into the bloodstream, you can guess it can get to many different visceral organs and cause infection there. So, it is not truly just a respiratory pathogen. It really can affect pretty much any organ system in a susceptible host. Like we talked about these projections, the fiber protein determines the target cell specificity. It's also important as a viral attachment protein. Once the virus attaches to the cell, the DNA enters into the cell and actually goes into the host cell nucleus. This is an important feature of adenovirus because there is actual viral genome entering into the host cell. And sometimes it can get incorporated into that host cell genome, which we'll talk about later. But the rest of the virus, it replicates in the cytoplasm and is assembled there and then enters the nucleus. And after the replication of the DNA, it is assembled into capsids and actually within the nucleus. The details of this, I think Dr. Hunt has again covered in viral replication, but she's talked about the early and late phases of replication. But remember that it's not a completely, efficient, 100% smooth process. There is a lot of room for error in the transcription, and a lot of extra and unnecessary proteins are formed in the process. And this leads to inclusion bodies within the nucleus. So it can be used as a telltale marker for adenoviral infection. This is a picture in high power showing you the nuclei which are infected with adenovirus, which do not look normal. They have some clumpy areas here, which are the inclusion bodies. And this is the electron micrograph. As you can see, this is an epithelial cell with epithelium with villi here, microvilli. And then this is inside the nucleus showing you the clumps of probably nucleoprotein or viral material. And these are the inclusion bodies. And sometimes under like scanning electron micrographs, you can actually see the crystallized viral particles, but that's a little high-tech. But these are telltale signs. So if you have, say, a person who died of, say, cardiac failure, just for example, sudden death, cardiac failure, autopsy showed myocarditis. When they actually do the specimen and look at the myocardium and they see this, that can be a tip-off, a clue into adenoviral infections. And if they're very sophisticated, they can do like immune electron microscopy to look for that. Now, the type of cells are mainly the mucoepithelial cells, and those are so-called the permissive cells. And in cell lines, there are certain kinds of cells that let the adenovirus replicate better than others. And those are called the kind of permissive cells, in which you have the infection of the cell is kind of killed in the process, lyses, and the adenovirus replicates, gets its job done, and then once the cell lyses, it's released to infect more cells. But there are some cells that are not so permissive or don't let the virus replicate so freely, and so in those cells, the virus does replicate, but not at such peak efficiency, and so those are the semi-permissive cells. But remember, those are type of lytic infections where the host cell is lysed. In some cases, especially like the lymphoid tissue, the adenovirus actually stays in the cell for the life of the cell. And this is important because it can stay as an occult infection that can later recrudesce if factors are permissible for that. And in cell cultures and in newborn hamsters, adenovirus actually causes neoplasia or oncogenic transformation and turns normal cells into tumor cells. So that is a phenomenon that's mainly seen in the labs, fortunately. But people always speculate that could adenoviruses cause cancer, and it's never been proven in human cases, but it could be possible. But it's just more important to remember that these infections can stay on for the life of the host cell, the latent infections. I'm going to go into this aspect of adenoviruses, but unfortunately now we don't. I think most of the research, if I'm not wrong, has been halted in this direction for use of adenovirus in vectors, because it takes the viral genetic material, goes into the host cell nucleus and gets incorporated there. So that ability has been manipulated and used in vitro to give the right DNA to deficient host cells. But I think they ran into a lot of problem with host responses, allergic and immune responses, and so that's right now on hold. It was being used for CF, cystic fibrosis, to give the missing gene, and I think some other immune deficiency conditions. Now, adenovirus is quite transmissible, and it is quite stable in the environment, can stay from anywhere from few hours to few days on surfaces. And it is relatively resistant to weak detergents and commonly used, hospital detergents, which is chlorhexidine. And the other thing that favors the enteric spread is the fact that they can survive with the acidity and presence of bile and proteolytic enzymes. And so these are the features of adenovirus that make it possible to cause clinical disease. This is important to understand in terms of adenovirus, and that is the time course of infection. I want you to go back and read from your books because it has the same picture that I'm showing you here that you can understand. But basically, the incubation period is not ultra short. It's moderately long and can be up to 10 days. At the end of the incubation period, you have the onset of symptoms. And at this time, this is the time when the virus is present in whatever secretions, or if it's a GI infection in the stool. But even before the symptoms come in the incubation period, virus is still present. So prior to symptoms, and also here after the symptoms have resolved, up to 2 to 3 weeks, you're seeing virus present. So the contagious period starts during incubation, pre-symptomatic, goes well beyond convalescence. And in the viremic phase, which we talked about, first epithelial, then epithelial-associated lymphoid, and finally bloodstream, is brief. And that occurs kind of during the peak of the symptomatic period. And then the host cell response, which is both antibody-mediated and cell-mediated, kicks in, and that kind of heralds the end of the viral infection. But the virus gets a good long time to replicate and be present. And so this is important in the transmission of infection. The other thing is the intermittent and prolonged rectal shedding. And so people who have had adenovirus infections can shed the virus intermittently for many weeks. And because of this high infectivity, the people who are around the primary case or the secondary cases can get it fairly effectively and efficiently. And again, like we talked about the iceberg, tip of the iceberg, most infections are subclinical. But the clinical infections that do occur are quite widespread or endemic, and then sporadic here and there little bursts, and then larger bursts that are the epidemic infections. Again, my favorite slide here for viral infections is going to pop up again. And the adenoviral infections that we see, what meets the eye is just the tip of the iceberg. Most of the people who have these could be asymptomatic but spreading the virus. These are data to show that adenovirus is present pretty much all year round. There may be a few temporary blips here and there. We may think of it as being a little more during winter here, but not really absent during the rest of the year. Now, the outbreak situations are interesting to note because they have been well described in people who are, in close inhabitants, daycare settings, residential institutions, as well as in hospitals, and particularly in military recruits. And they are really, they're treated in they're housed in very close quarters. There's a lot of strenuous physical exertion, probably a lot of stress, and so these are factors that lead to the spread of adenovirus, and outbreaks have been well described. I'm going to talk about that in a bit. But swimming pool users also, because there is spread through contaminated water, and so those can be, that can be the route to spread for GI and respiratory illnesses due to adenovirus. Now, the routes of transmission are by direct respiratory droplets and fecal-oral route as well, and through poorly chlorinated water and surfaces because it is able to survive on surfaces for a few hours. Going on to the clinical syndromes, again, there is a big table in your handout which kind of summarizes the clinical syndromes, but just remember the syndromes, forget the types of serotypes of virus. So I'm going to go over some of these, starting with the respiratory syndromes. And then the first one here is actually I'm starting with the lower respiratory disease, which is called the acute respiratory disease caused by adenovirus. And this can be in the form of tracheobronchitis or pneumonia. And as I said, outbreaks have been described in military recruits because of this. And the most frequently associated types are 4 and 7. And really, predominant fever, malaise, chills. In fact, they've described fevers up to 106 degrees, which is a very high fever for an adult. And this is not a mild disease. It can really be debilitating. This is a section of acute respiratory disease on postmortem due to adenovirus. Notice here there's an area of consolidation where the loss of the normal lung architecture here. And these are quite fatal diseases in immune-compromised patients. I'm going to give a little more information on that. But going from lower tract to upper tract, pharyngoconjunctival fever is a syndrome where you have pharyngitis, headache, and fever, and other constitutional symptoms, and conjunctivitis. And because of the involvement of these areas, you have cervical adenopathy, and you can also have preauricular adenopathy. There's some association with GI symptoms, and it's not clear how the respiratory symptoms and GI symptoms intermesh here, probably because of the same virus. But the common types are 3, 4, 7, and 14, and pharyngoconjunctival fever outbreaks are well described from contaminated water and swimming pools. Many outdoor recreation parks, you may have heard of these outbreaks where people came down with conjunctivitis because of poor chlorination. A specific adenoviral infection in the eye, besides the conjunctivitis, is called the epidemic keratoconjunctivitis, where there's an epidemic of corneal and conjunctival infection. This is apart from the typical viral conjunctivitis, which is a follicular conjunctivitis. And as we talked about the pharyngoconjunctival fever, they can also have conjunctival symptoms. This is a stage of early hyperemia of the conjunctiva where you see these dilated blood vessels and a reddish blush over here from the conjunctival injection. But going on to the lower picture, you see intense conjunctival erythema. Actually, there are subconjunctival hemorrhages here and ecchymosis, and this is a very painful condition. And when it gets into the corneal phase, there's actually involvement of the cornea as well. And these are the symptoms: the irritation, redness, tearing. There's a lot of pain, as I said. When it gets into corneal involvement, there's photophobia, and there can also be associated symptoms like fever and malaise. The signs that one would see, we saw in the picture, the redness of the conjunctiva. When it gets into the cornea, it involves the limbus of the eye, which is the pericorneal area of the conjunctiva, which becomes intensely red. And then you see the involvement of the cornea on slit lamp in the form of diffuse and progressing onto focal epithelial keratitis. At the point when you have keratitis, you can have intense pain, photophobia, and decreased visual acuity. Associated with that is the preauricular lymphadenopathy. Now, the epidemics have been described in summer times, closed living situations, as well as in schools and contaminated water, swimming pools. And interestingly, nosocomial infections, where you use shared ophthalmologic equipment like tonometers and all, which are used to measure corneal pressures, and also fluorescein dyes. When you put the solution, if you touch the conjunctiva, and you can pick up the adenovirus from a patient and spread it to the next one. And of course, hands and fomites are also important in the spread of virus nosocomially. Going down to the gastrointestinal types of adenovirus, we talked about serotype F and serotypes 40, 41 from the subgroup F, which are mainly thought to be gastrointestinal pathogens. There are other adenoviral serotypes that can cause GI infections as well. Now, these tend to be severe diarrheal symptoms in younger children with longer clinical symptoms and longer incubation periods. So compared to the viral gastroenteritis, which we'll talk about in a bit, these have a slightly longer incubation period, longer days of being symptomatic. And the interesting part is these can trigger the lymphoid tissues in the gut to swell up so much that they can lead to intussusception. and mesenteric adenitis. This picture over here shows the process of intussusception. And for those of you who are not yet in the clinical arena, who you may have read about this through the pathology, but basically if this is the normal gut, the smallest intestine, the intussusception comes in like this, where one part of the gut gets telescoped into the other. And this is the proximal and this is the distal gut. So at this point, the vasculature here gets constricted. And so the blood supply to this part is cut off, and this part gets hemorrhagic, gets sloughed off. Of course, you have obstruction here, and you have intense inflammation. So this is the process of intussusception that is well associated with adenovirus. Now, it is not to say that adenovirus causes all cases of intussusception, but it's important to note this relationship. And this is a picture over here that shows you the same process that I tried to describe here, where this is the proximal gut getting suffocated here, and the distal gut comes and telescopes on it, and you have this intense hemorrhagic kind of disease here. Intussusception is something we'll talk about also, interestingly, with the rotavirus vaccine in the next lecture. The spectrum of disease is quite large, and so we have other organ involvement, and chiefly in the genitourinary system, we have this syndrome of acute hemorrhagic cystitis. Has anyone heard of this or know about this? It's not totally uncommon, but you can have fever and dysuria, mainly males are affected, and sudden blood in the urine. It's quite alarming. There's actually frank red blood in the urine. And this is caused by types 11, 7, and 21, and it probably has to do with the fact that the adenoviral infection is causing hemorrhages in the genitourinary tract. And other spectrum of involvement includes orchitis, pretty much a lot of different involvement. And in one study, they actually looked at, in a male STD clinic, they look at non-gonococcal or NGU. Are you familiar with that term? Non-gonococcal urethritis. And they were able to find that adenovirus was quite prevalent, and they found certain types 2, 8, and 37 as serotypes that were associated. So really a big spectrum. And to complete the list, you have involvement of myocardium, heart, meningitis, encephalitis. You can have a peculiar viral rash and even arthritis. But the people who are really hard hit are the young children and immunocompromised hosts. And there are several descriptions in the literature about bone marrow transplant and solid organ transplant and other kinds of immunocompromised people who are hit by adenovirus disease. And it's not clear whether the infection came because it's a new infection in a compromised host, or whether it was that latent infection, that latent virus within the lymphocytes or lymphoid tissue that, because of host immunosuppression, came up and reactivated. So there are case reports of both kinds where they could trace it back to latent tissue and trace it back to the donor tissue. So these people get hit very hard by adenoviral infections, often fatal. A lot of pneumonia in bone marrow transplants due to adenovirus can be fatal. And I want you to remember this because you will be seeing in your career as clinicians a lot of immunocompromised patients. It can cause the severe type of pneumonia called the necrotizing pneumonia, fulminant hepatitis, and even DIC and rash, and basically all organs get hit very badly during the viremic phase of illness in immunocompetent patients. This is from an immunocompromised patient showing the respiratory involvement of adenovirus. Again, note the intranuclear globs over here, which is magnified in EM, as I said, as crystalline viral viruses within these cells. So important infection, wide spectrum, pleomorphic presentations, and so we need to know as clinicians to suspect it and also how to diagnose it. And a viral culture is a great method, but it is not a quick method, and it is labor intensive. And so you can do the viral transport and viral culture, but what we find is quicker in a clinical setting is to get the specimen, which is usually dependent on what site is involved. So if it's conjunctivitis, you'd swab the conjunctiva, and to get a rapid diagnostic test on it. Now, because of the prolonged viral shedding and the shedding of the virus in the stool and pharyngeal sites, we tend to use the pharyngeal isolation of virus as more predictive of a recent or current infection than stool shedding, because if the person is shedding it in the stool, it could be that they had an adenovirus infection in the recent past more than 2 or 3 weeks ago. So the quick rapid diagnostic tests that we have available are the DFA and the, of course, nucleic acid and PCR. These are not available as much in clinical labs, but well described in bone marrow transplant patients. They actually do the PCR for quick diagnosis. And then we have a technique called a shell vial culture, which is basically a viral culture technique, but it has a rapid, more kind of rapid result because it stimulates the virus to grow better. The enteric adenoviruses are difficult to culture, and therefore culture is not the primary method of confirming clinical cases. They need a special cell line. And so the test that is now commercially available is an ELISA test on stool for types 40 and 41. Again, spread of infection is important with these simple measures: hand washing, contact precautions, and as we mentioned, in outbreak situation, there may be a defect in the chlorination of water. So important to address that. And in nosocomial ophthalmologic settings, not to share single-use vials for drops, and to sterilize the equipment appropriately. I'm going to talk about the vaccine, and then I really need to zip through to get you to the GI viruses. But the type 4/7 oral live attenuated vaccine was very restricted use in military recruits. And it was used back from this, it was recognized that these group of people had major adenoviral disease burden. So in the 50s and 60s, after that recognition, in the 70s onwards to the 90s, the vaccine was available for them, and it was quite successful. But the manufacturer, which was Wyeth, had major problems in sustaining vaccine manufacture, and they said they had outdated equipment, and so the vaccine was halted manufacture in the 96. So this picture over here shows you about what happened when the vaccine was actually halted here. It was some units were available, and so it was kind of used off and on depending on availability. But starting here, when the vaccine was not available, you were seeing these big blips of hundreds of cases. And this is not far from home. This is right here at Fort Jackson. And so this shows why it was important to give some kind of protection. Up to 50% of recruits that came into the military were naive and susceptible to adenovirus disease. Put them through that barrack-type training, got really sick, many of them. And this had a major impact on the training, and of course, when you translated that into terms of dollars and cents, it's a lot. So they came up with this vaccine that now a new different company is going to take over production for, and it looks like this. It has a viral core with a live attenuated virus here, and then the material in the outer core, and then a polymer coated to make it a tablet. So the thought is that to give all military recruits this vaccine within 2 hours after they hit that training camp, and prevent adenoviral disease. So that's where I end with adenovirus. Do we have time for a break, or do you want me to go straight to the GI viruses?